All right, we'll talk a little bit about colorectal cancer screening now. So colon and rectal cancer are still the third leading cause of cancer-related death. But there is certainly very good news, and I wish lots of different organs we could say the same thing, which is this very steady decline in the incidence that we've seen since the 1980s. Interestingly enough, reflecting changes in trends before we started really implementing screening strategies. But certainly there are some studies suggesting that the implementation of those screening strategies has had a lot to do with this very steep and steady decline that we've been seeing over the last years. There are also some data that's a little bit worrisome, which is that huge difference that there is in this decrease in the incidence, and basically African Americans carrying a much higher incidence, which has resulted in the widest gap in terms of mortality for colorectal cancer between non-Hispanic whites and African Americans. So certainly much more work to do in this particular group that's disproportionately having a higher burden of this disease nowadays. These are the main screening tools that we had for a while. This is the latest edition here. And we usually distinguish them in between direct visualization tests. Those are in general invasive tests, but they detect both polyps and cancer. And then we have the stool-based tests. Those are non-invasive, but they usually they basically detect cancer. They perform pretty poorly when it comes to detecting polyps. In general, in the U.S., we've really been relying heavily on colonoscopy, and for many of us, colon cancer screening has been colonoscopy. The issue with colonoscopy, though, is it's no easy proposition. It is intensive, and it is, as we said, an invasive test. So, and it's fair to say that actually this is probably the only country on earth that has actually been relying on colonoscopy as the main screening strategy, while the rest of the world has been mostly using this stool-based test for a primary source of screening. And this is where we were in 2012 in terms of colorectal cancer screening. We are in a good position here in New England. In general, we're about in the national average in the higher 60% of the eligible individuals that are being screened for colorectal cancer. But that's leaving us with about a third of all eligible individuals who have never undergone colorectal cancer screening. And the more worrisome part is that actually this level has kind of plateaued. Over the last 2 years, we have not made any advances in terms of national averages for colorectal cancer screening, which gives us a lot of pause. So truly the goal here is maximize the number of persons who are screened, and we are far from that at this point. And the question that is being asked is like, can screening rates be increased when all screening options are considered? And that's been the question that the USPSTF posed and worked on for a while. And this is very recently published position from the USPSTF in terms of colorectal cancer screening that's really collecting this kind of distressing situation about lack of advance in terms of colorectal cancer screening, and can we offer the other choices to individuals who are not necessarily interested in colonoscopies. So a few things to say. First, there's the limited data to permit direct comparison of screening methods and screening programs over time. So we do have good data in terms of one-time effectiveness, but we don't know the long-term effectiveness, which is really the only one that matters. So we do like that data. And because of that, the USPSTF, what they did is they commissioned to the Cancer Intervention and Surveillance Modeling Network to inform recommendations through analytic modeling. So analytic modeling, for all it's worth, it is modeling, but unfortunately we just don't seem to have better tools to really identify where the differences are in terms of outcomes when we're using different screening methods. Sensitivity of the test over time is no question more important than single test performance, as we were saying before. So that's how we should look at, and those are the kind of studies that we're lacking. And analysis should include benefits It should also include harms and burden of colorectal cancer screening. So going over the different options here, and very briefly, FOBT was the first non-invasive test, fecal occult blood test. This there have been a new generation of the ones called Hemoccult Sensa that they've definitely increased sensitivity. But after that, the feed testing really has taken the stage here in terms of stool methods, because they do seem to have a better accuracy than FOBT. And more recently, we've seen the approval of the feed DNA, which is basically a mix of the feed plus some DNA markers. And the problem with that is that while sensitivity is just a little bit better than the particularly feed testing, which we were compared to, but the problem is the specificity, which is much lower. So this is generating many more colonoscopies. Another important aspect also is cost. We're talking FOBT $4, feed $8, feed DNA $500. When it comes to the direct visualization tools, as we said before, colonoscopy, the good thing is that if it's normal, you're good for 10 years. So that's particularly appealing when we have highly mobile populations who we think are not going to be very interested in adhering, or we're not going to see them often enough in clinic to make sure that they would get their screening. So that's an important consideration to make also. CT colonography, we kind of bump to the same aspects that I've been hearing before in terms of the incidental findings. Those have been reported about 45%, and that's really what's been the big pushback in terms of not using CT colonography, because of the great amount of further tests that this is generating, finding all those incidental findings. Flexible sigmoidoscopy was popular many years ago. This has really, the availability of this has gone definitely down. And we do know, particularly there was a very well conducted study that showed that actually flexible sigmoidoscopy every 10 years plus feed screening every single year is has a better outcome in terms of screening than just flexible sigmoidoscopy alone. So what have been the conclusions that the task force have come up through this process of the modeling on all these different approaches? So certainly benefits of early detection and intervention for colon cancer screening seem to decline after age 75, and that's why clear recommendations have been made between ages of 50 and 75. But among older adults previously screened, at best there's only a moderate benefit to continuing screening during the ages of 76 to 85. But if those individuals were not previously screened, they seem to be to benefit more. So if they are in a reasonable state of health, those individuals ages 76 and 85 can also benefit from colorectal cancer screening. And finally, benefit in adults 85 of age and older at most seem to have a slight advantage when we're doing screening, but of course we do have a much more important number of adverse events, so the balance tilts a little bit. So it's still on an individualized basis, but we're starting to stay a little bit more away in these individuals. So they looked several things at this modeling. The first one, the CISNET modeling, is the live years gained per 1,000 patients screened. Here we have the different screening modalities at the very bottom, colonoscopy. And as well, we can see here, out of the 1,000 screened cases, the live years gain with non-colonoscopy strategies compared to colonoscopy strategies are about 90% to the number of strategies that use colonoscopy. So very close, not so much of a distance actually, the difference in terms of outcomes when we are using this, basically the majority of the other techniques in comparison to colonoscopy. When we look at live years gained per 1,000 screened, the difference is also very close to, in terms of not so much difference using the different techniques. Then looking at deaths averted per 1,000 screened individuals, we see about 3 to 4 deaths difference among different screening options per 1,000 screened individuals. And when we look at complications per 1,000 screened, obviously there's 3 to 4 complication difference among different screening options per 1,000 screened. So colonoscopy does have the highest number of complications, but because feed DNA testing results in so many colonoscopies, the difference is not so big at the end of the day. And we are basically left with about half of the cases in the non-invasive test used. Finally, lifetime colonoscopies, the number of colonoscopies that will be performed using the different approaches. Again, of course, colonoscopy, it's over here, but non-colonoscopy strategies result in about half of the number of colonoscopies. So it's not that we are decreasing the number of colonoscopies to 10, 15%, which was initially what we thought, but basically we are left in half colonoscopies. Obviously, so you're using a very expensive test, for instance, this one here, certainly the advantage of just doing half of the colonoscopies doesn't seem to be significant enough to warrant using this as your preferred test. But in any ways, I think the take-home message that the USPSTF wanted to make sure that we take is that they are no longer prioritizing a single strategy, but what they do is offering different options, different choices with the hope of increasing colorectal screening uptake. And what they are recommending is that the clinical decision involve more consideration than evidence alone, and individualized decision making to the specific patient and situation. So we should really start taking into account patients' preferences. When we're talking about an invasive test, we have morbidity and in some extreme cases mortality. So we should be presenting this information probably in a better way than we are presenting it right now. And also, we have a capacity issue. There are many areas in the country and that we just don't have the capacity to screen everyone who's eligible with colonoscopy. Third consideration, which the USPSTF does not get into, is cost. And obviously, colonoscopy is no cheap approach to screening. Therefore, that is something when we have such a large pool of eligible individuals, if we see such a small difference in terms of outcomes, when we start thinking about public health and what we should be putting our resources, we should really think twice about what the outcomes are, what the differences are in outcomes. That said, I would like to share that information here too, which is this is trends in colorectal cancer incidence, in this case in men. And as we said before, here we have the US with this very nice drop in incidence. And I would like to point out how all these countries that have screening programs that are non-invasive screening programs in place, not using colonoscopies, they are seeing still a significant increase in the incidence, and they have not seen a decrease. So I wonder if doing colonoscopies and removing lots of polyps that many times probably they don't mean much, but some of them probably would mean, makes a difference. So I really would like to leave it here, some food for thought about where we're going. Thank you.